Lateral knee dislocation is basically hyperextension of the knee. It can be classified as per Thoric classification. Type 1 is when there is a subluxation or hyperextension, when there is hyperextended knee and the range of motion is more than 9 degrees. Type 2 is anterior subluxation of tibia and the range of motion 30 to 9 degrees. And type 3 is anterior dislocation of tibia with a range of motion less than 30 degrees. It is important to know the associations. So a congenital knee dislocation can happen when the quads are weak. So this can happen because of L3 involvement. The most common causes can be myelomeningeal at that level. The other cause will be arthrogryposis. The other association is metatarsus adductus, Larsen syndrome, clubfoot, and DDH. Regarding the treatment, I will go for MUA with a long leg cast for a patient. Gentle stretching and physiotherapy will improve the range of motion. If I am failed to do 30-degree of flexion in 3 months, I will plan for operative intervention in the form of quadricep lengthening and BYZ-plasty. I will do anterior capsule release, posterior capsulorrhaphy, and hamstring tendon transposition with collateral ligaments reconstruction. If both hips and knees are dislocated, then treat the knee first, as you cannot do a harness if the knee is dislocated. Larsen syndrome is a ligamentous hyperlaxity with multiple joints dislocations, hip, knee, shoulder, radial head. Close reductions are really successful. Clinical features are flattened nasal bridge, prominent forehead, hypertelorism, that is increased distance between the eyes, cervical kyphosis, potential lethal, long fingers, and club feet.